All right, so I wanted to share with you the webinar series team. It takes a whole team of people to put on these webinars for you. And so thank you to the team and for everybody who works to make this event happen. And if you are interested in learning more about Lecturio puts on these events for you free of charge. If you're interested in learning a little bit more about Lecturio and our AI solutions, or you can use that QR code on your screen. If you're on your phone, just take a screenshot and that will let you set up a demo to get some more information about Lecturio. I'm your webinar host. I'm Sarah Keith. I'm the Director of Learning and Institutional Success here at Lecturio. And our guest speaker today is Dr. Verity Shea. She's an assistant dean at New York University Grossman School of Medicine, a clinical reasoning researcher in the Institute for Innovations in Medical Education, and a member of Lecturio's NEJM Healer Advisory Board. So I would like to hand it over to you, Dr. Shea.
Wonderful. Thank you so much for having me. So as Sarah mentioned, just a little bit of my background. The one other thing I'll add in my clinical hat, I am a hospitalist, adult medicine hospitalist, so caring for patients admitted to our inpatient units here at the Bellevue site at within our NYU affiliate hospitals. So because I think that also sort of colors the lens of kind of we view these things. And again, really focus within clinical reasoning and how we obviously the landscape is changing and how we think about curriculum and assessment in the new landscape of artificial intelligence within our clinical reasoning process. Just kind of a few disclosures. I get the pleasure of being on the Lecturio advisory board, and it's really a great group of individuals and program that get to collaborate with. Won't be the scope of what I talk about today, though. And over the next, we have 45 minutes. Obviously, want to leave time for questions. Just talk about like the problem, of diagnostic errors and what we know currently about clinical reasoning and best practices of how to teach and assess it, and how artificial intelligence can be a game changer here and help move the dial, hopefully, on diagnostic errors and improvements in diagnostic performance. And the goal of this is for, everyone here is probably on a different spectrum of where they're at and using these tools and comfort with these. And so at least just move you one peg on the dial of wherever you are now of using these further in your educational settings. So a little bit just the scope of the problem, and many folks might be familiar with this report from the National Academies of Medicine, now actually almost a decade or exactly a decade old, really shedding the light on the pervasive impact of diagnostic errors and that has on our healthcare system. And this is certainly despite best efforts, fantastic, multidisciplinary teams caring for patients of something that just is really still kind of very, very pervasive. They put forth several goals for improving diagnosis, and I'm going to be, where I'm going to be focusing more in on is about health professions education training. So that's both curriculum and then certainly assessment, and that gets into the developing and deploying approaches to identify and learn from diagnostic errors and near misses. Granted, this was written, certainly there were other forms of artificial intelligence when this was written, but certainly not large language models, but how health information technology and specifically artificial intelligence can really help us here. I'm going to do some level setting of what we know about just the human brain, because I think it's really important as we then layer in what we know about AI, that we don't forget all the foundation that we know from clinical reasoning theory and what we know about best practices and what we know about the clinical reasoning process. And so to not to build upon that. So I'm going to do a little level setting first of what we know just as humans of how we operate. And this is the conceptual model from that report. That's kind of breaking down what happens. Obviously, a patient first has to experience a healthcare problem, will engage with the system. As clinicians, we're gathering that information, whether that be from a history exam, other data, generating our working differential, and deciding on diagnostic testing and treatment. And certainly this is an iterative process. And of course, communicating that with the patient is an important part of this process. And then just kind of a little bit more drilled down, because I'm going to be talking more about the cognition and not just like the systems level things, but sort of more as the clinician and the cognitive processes of what, and this is seminal work from Judith Bowen, of kind of what's going on in our brain of formulating, and I'll talk about these more, and I'm sure many folks are familiar with the concepts of problem representation and illness scripts, and I'll talk about those a little bit more on the next slide. And just to add of like where things go wrong, often it's multifactorial, both systems related and cognitive factors, but a large percentage of the time there's a cognitive factor in terms of a error within our cognitive process of how we arise at diagnoses. And so what do we know about, again, not getting to AI yet, I'm going to layer it in just a minute, about just from the decades of literature about evidence best practices to teach clinical reasoning in the pre-AI era. And these are the things that we know and that have evidence, the best evidence for. And bucket these into strategies that promote knowledge organization and strategies that promote structured reflection. And so to delve in a little bit deeper on what I was just talking about on the last slide, teaching the concept of problem representation. So really abstracting out what are the key features of this patient's presentation, the time course of the illness, and is that acute, subacute, chronic, putting things in like unified medical concepts. So if it's diabetes and hypertension and patient is a smoker, cardiovascular risk factors. And then that has to do with pattern recognition with then how diseases typically present. So illness scripts is like the prototypical presentation of disease. And then diagnostic schemas just being the systematic way to think about a problem. So an organized way to think about chest pain, and kind of what is the systematic approach to chest pain. And so these are things that have been increasingly integrated over the last decade more into clinical reasoning curricula within undergraduate medical education. And then in the structural reflection bucket, thinking about diagnostic timeouts and kind of framing of, what else could this be, or what data am I missing, what doesn't fit. And I'm going to show in a few slides of what we use in our curriculum of layering in AI. And this is probably for right now, again, this is a very rapidly moving landscape of sort of where AI can really help in sort of that structural reflection. I'm going to delve a little bit more into that in a few slides. And then also within that structural reflection, like what's the worst thing this could be? Doesn't mean you have to always work that up, but always to think about it. And so I think it's important to think about this, and I'm going to circle back to this when we think about, well, what should we be including in our curricula about AI, and how does it relate to what we know generally about the clinical reasoning process and what works and what doesn't work. And so it is a game changer. It's here, whether we like it or not. I know people have mixtures of feelings about it, but our learners are using it, like, certainly our, fellow peers are using it. We need to teach them how to use it right. And best practices, limitations, what are the guardrails, right? We can't ignore its presence. And so just a very brief on some of the technical, and some of this, again, many of you might already be familiar with, but just to kind of do just a brief foray into this, how does it work and how is it different than, previous artificial intelligence technologies? And I'm going to be talking mostly about large language models, that's text-based generative AI. There certainly is then ambient AI and audio inputs, visual inputs. And so generative AI is kind of like the larger bucket for all of that. And so ultimately assembles for a large text-based large language models, assembles billions of texts. And depending what model, it's going to be trained on different stuff. So it might not be medically specific information. The prime example, the one I think that's most used and known is GPT, is not specifically trained on like medical literature and PubMed articles. All that text is converted into analysis called tokens. Powerful computers read through all of that. Certainly is given iterative feedback by human researchers on like what's the, there's predictable patterns in human language. And so what's the best sequence of words? And so then ultimately when given a new prompt, generates one token at a time and predicts what the next word in the sentence is. And will kind of generate new language based on kind of what it's learned, based on looking at billions of samples of text, what are patterns in human language. And this is just to kind of highlight, this is already, already like year plus old, but I think it just kind of represents nicely just kind of that point of depending on the model, it's trained on different data. And so the things on the left is trained on non-medical specific data, so Wikipedia, websites, whatnot, and the things on the right are purely on electronic health record data. And then you have in the middle, academic papers and abstracts. So it's always important to kind of know a little bit about what the model that you're using. And this could potentially lead to some limitations, and it's trained up to a certain point. And there's things called like model cards where you can look up, the last training date to, January, 30th, 2025. So any new things that came out since then wouldn't be trained on. So that's just something always just to kind of be aware of. And then, there's lots of different resources for prompting best practices. And so I'm just going to just kind of briefly go over this. And there's some references here. And I'm going to show you more resources as well in a few slides. But it's really about, and many of you probably are using these tools already, about getting hands-on, learning how to prompt, being specific, giving context. You are a hospitalist physician taking care of a patient, on the wards. But not getting too jargony as well, and kind of striking the balance. And it's all about iterating and refining, and sort of like kind of this back and forth. I will also get into the second half of this is just kind of frontline use, how you can kind of actually develop tools. And a lot of my work is in the assessment space of kind of pipelines to kind of put in place that are not dependent on the frontline user putting in the prompts, if you will, and kind of developing more robustly. So I'll talk about that as well a little later on. I kind of touched upon these already, but just to kind of highlight before that I talk about what it can do and some of the clinical, AI clinical reasoning literature. I talked a little, already about some of the limitations of knowledge base. It can't fully understand context, ethics, and values. You can prompt it to be like, this is the value, of the value of my patient. What would you suggest doing in this context, right? And so it's not going to come up with that on its own, but you can kind of get there potentially with prompting. Hallucinations have gotten infinitely better. Again, the pace of change of new models and their performance is just astronomical. But at the end of the day, it's still, and I'll talk about how we kind of hit this home within our clinical reasoning curriculum, integrating AI. As the humans, we were responsible for critically appraising the output and integrating this into our reasoning. Will this look different a year, 2, 3 years from now? Very might well be, but certainly that's where we are now. Certainly there's bias in the data it's trained on, so there can be bias in the output. So it's important for, again, that critical appraisal. And you have to be careful of where you're putting what information. And so, find out from your institution what's accessible in terms of within your internal, internal instances within firewalls that are HIPAA compliant. You can't put any patient-sensitive data or student-sensitive data out into public tools. And so that's always just something really important to think about. So what can it do? Rather than focus on just the can't, the power of there's, again, this is the literature is so fast here. And so this is just, a little bit of a sampling, and there's new articles coming out, essentially every day. Plenty of literature showing that large language models can outperform MDs on diagnosis. And this is just, again, a sampling of some of those articles. I'll give a big caveat. I will say all of these are under controlled circumstances in some way or the other. So they're CPC style cases, so curated cases where the data is fed in. Even the last article, the superhuman performance of large language model on the reasoning tasks of physicians, they used real clinical ED data, but it wasn't live in the moment. It was they fed that into the model afterwards and saw the performance of the LLM. And as we know, the clinical environment is noisy, it's complex, clinical reasoning is context dependent. And so, I think then just kind of with that caveat of these conclusions, that doesn't necessarily mean yet is the operative word, I think, with all of this, that's going to outperform the doctor in the clinical environment live. And that's something that, again, we still, obviously there's going to be more studies to come on this, but that's kind of our current state today on this. And so we still need to teach clinical reasoning. I really like this. This was a perspective from the Dean of Medical Education at Harvard. This is now actually almost 2 years old, but still I think rings true. We still need to teach higher order critical thinking. And if anything, it remains that much more essential. LLMs are probably going to be able to help automate the straightforward stuff. And it's going to be the nuance, the edge cases, the more challenging cases, all the more reason that we still really need to teach, higher order critical thinking. But as I kind of set up at the beginning, we're not getting it right all the time, and we need to do better. And so again, the potential of the future is the synergy of human reasoning and AI has the potential to improve diagnosis. And I'm going to go over on the next slide some of the literature we have thus far, which we haven't borne this out proven it yet. Again, there still needs to be the data to come, but I think, that's why we need to ground this in what we do know about clinical reasoning theory when we teach it while the literature is still building. And so I think kind of going back to some of that clinical reasoning theory, and this is with a little bit of an older model, so this is evolving too as newer models come out, but ultimately how the synergy, how this might help us improve diagnosis. And in this article, it was a classic kind of CPC style case where they gave an aliquot, the human responded, their thought process, the LLM responded with their reasoning. And they just did a comparison of the human's clinical reasoning process versus a GPT. And I won't kind of read out everything here, and I'll show a snippet in just a second of these comparisons of those outputs. But one of the things and where this can be particularly helpful is in the structured reflection and in broadening the differential. As you'll see here, broad differentials, which include rare diseases that might not be at the tip of our tongue, and some of the comparisons between what GPT was able to do versus the human. Not as good at probabilistic reasoning. Again, current models, again, that's a changing landscape as more advanced models come out. And so this is just to show you a snippet from those aliquots, the human on the right, kind of short and sweet to the point, and GPT on the left, giving a little bit of a broader differential. I didn't remember what Kogan syndrome runs. Maybe I learned it in med school, but ultimately it ended up being GPA the case. But there might be an instance where it's not, and this diagnosis is not something that might be at the tip of your brain if you're not seeing it all the time. And so again, we don't have the data yet proving that AI and human reasoning is better, and we're still learning how best to synergize. I'll say, and again, this is a sampling of the literature that's come out thus far about the synergy. And really the take home here is that humans and LLMs did not perform better than LLMs alone or humans alone. But a big caveat is the humans weren't given any specific instructions in these. They're essentially here's a case, here's an LLM, use it. And so I don't think we can make any conclusions here that yet that humans and LLMs are not better. I think we need to know well, how do we best use it? And that's where we have to go back to, for now, while more studies are coming out, what we know about clinical reasoning theory and what has worked historically, and some of those evidence-based best practices. And so bottom line, this is the future of integrating AI into the diagnostic process. And so we need to, teach about how to best use it. And I'm going to show you a little bit what we do in our curriculum here at NYU. Again, this is going to be a moving target. So this is what we know today. This might be different a month from now, and it's something we have to, constantly sort of iterate and rethink. So this is just an overview, and granted, it's honestly changed since we published this article, of just some of the curriculum that we have. And I'll highlight, that a lot of it is really getting hands-on, and how do you integrate this into enhancement of your clinical skills, and obviously clinical reasoning being one of those. And then certainly talking about sort of ethics of the use and legality, and all these things are kind of important when you're thinking about kind of what curriculum to build. And that this needs to be kind of full thickness, because as faculty, and I think it mostly is faculty, but there might be some trainees as well on the line. We're learning that along with our learners, with our trainees, with our residents and our students. And so while they might be more savvy in the technology itself, we obviously are the expert diagnosticians, right? And so we can kind of certainly bring that to the table. Granted, they might, be better knowledgeable about how these technologies work and prompt engineering. But again, that's certainly we bring that expertise about as clinicians to the table. And then the other thing, before I'll kind of show a little bit about how we actually integrate it, is they need guidelines and guardrails, and the things I talked about data privacy and what you can and can't use. And so this is our education policy. We also have a clinical policy too. And bottom line is you're responsible for what that gets put in a patient chart, and you have to where you put what information. And so this is overview, kind of some of the highlights that's written here, and we have kind of a certainly if it's just education study tools and creating flashcards, you could put that in public tools. But certainly if it's patient data, that's something you have to be careful about. And then things of like not completely copying and pasting patient notes and putting it, even if it is in a private instance. And so this is a tool that we use for a curriculum. This was created by Dr. Mark Triola, our Institute for Innovation's Medical Education Institute Director, of which I am faculty in, and worked with him on the diagnostic reasoning cases. This is a publicly available website, so you all can use this, take this, implement it in your own use it for your own curriculum. And ultimately just kind of show there's like on the landing page a whole bunch of different resources about prompting and how you stay up to date on these things, and then a bunch of different use cases on the left. The education guidelines I just showed, those are also publicly available through this link here. You won't be able to, unless you're at NYU, you won't be able to access this as our internal instance, but there's also a link pass through to the public chat GPT as well. And so I'm just going to show a primer of one of these use cases and how we actually sort of introduce this and basis of like how you use this as a structured reflection tool or decision support tool. And so the diagnostic reasoning use case on the left, and we have prompts that get them started and then give them just a sample case. And these are made up cases. This is not real patient data. So this can go into the public tools of everything that we have on the site. There's no actual real patient data on the site. And we have them, again, grounded in what we know about structured reflection. This is a classic kind of structured reflection tool that's been used in clinical reasoning curriculum, for quite some time, but then like layering in the generative AI piece. But we always have them like, think about your, give them a clinical case. Think about your human reasoning first and the supporting and opposing features and thinking about, having them commit to their pre-test abilities and level of certainty, and then input it into generative AI. And again, we have prompts that get them started, and then have them reflect, how did that change your reasoning, if at all? Did it affirm things? Did it change your level of pre-test probability? Did it change, again, your prioritization and kind of next steps? And again, that ultimately they are responsible for teaching them how to critically appraise this output, and that they're ultimately responsible kind of for the decisions made for patient care. And generative AI can be very confident. And so that sounded like one of the guardrails and being like, just because it sounds confident does not mean it's right. And so I think there's always kind of the balance of when you introduce this and the earlier learner who obviously doesn't have their clinical acumen built yet to have the confidence to say like, no, it's wrong, or like just assuming that it knows better than them. So those are always just some things to always balance here. At the same time, they're using it, and so we want to at least make sure we give them sort of some structure and how to use it correctly. And this is just to kind of zoom in on what some of those prompts are, kind of mirroring that structured reflection tool that we give them to like get started, but then to really sort of iterate and iterate on their prompting and have sort of a dynamic back and forth. And so that's what we do on the curricular front, and that's just kind of a primer. There's a whole bunch of different use cases, about patient communication and documentation. And again, just for time, I'm not going to get into all those things, but there's so many other kind of clinical skills that can help develop practicing with a virtual case, giving feedback. And so with that, I'm going to segue to the second half, and this is where more of my primary research is. In use of AI in assessment of clinical reasoning, and which is a challenging thing. And it's challenging for many reasons to assess clinical reasoning. It's a process. It's not one isolated skill. And so kind of yes, there's the ultimate outcome. Did you get the right diagnosis? But there's so many steps along the way to get there. Do we have all the same shared mental model of like what is good reasoning? It's so dependent on context. And so like the number of assessments you need to make a judgment it can be potentially onerous of collecting that assessment data. And sometimes this is happening in our brains. And so like actually getting this out and be able to kind of assess our learners and where they're at. And there certainly are human assessment tools out there, and something, again, we expect of our learners, whether it be a UME learner or a GME learner. And I know, not everyone here is in the United States. There's some of the competency frameworks within the United States, or you all have, I'm sure, similar equivalents of competency frameworks in your educational space. And there are tools out there, right, that exist. And for documentation, the DIA assessment tool, myself and colleagues iterated on that for the revised idea assessment tool with a little bit more specificity and anchoring. Oral presentations, the assessment and reasoning tool. And these are all great tools, but there's only so much time in the day to assess all of our learners, gather all the data, and AI can be a powerful tool to supplement and be grounded in these shared mental models and be more kind of reproducible and potentially less variable than different faculty or supervising residents of students. And so there is, definitely some things that have come out in different spaces with use of AI and assessment of clinical reasoning. And I kind of already touched about, how it can help overcome some of these challenges. And there's been, articles about, and I'll talk a little bit more specifically about my work of use of assessment of clinical reasoning documentation in the electronic health record. There's been use of it for assessment of OSCE notes. And as well, just kind of open text, free clinical reasoning, open text exams, so like clinical reasoning essays or narrative responses. And so again, using it can really help enhance, potentially have more consistency in the quality of assessments and help gather more volume of assessment data to make interpretations about our trainees. And so I'll do a little bit of deeper dive in some of my work specifically, just to kind of, for the last, 10, 15 minutes to wrap us up. The first one I'll talk about was a collaboration between us and University in Cincinnati and really trying to create a tool to pilot and implement in a different site and kind of learn about, what are the things that we need to do to transfer kind of technology and how does it vary. And ultimately for this is was a goal to create different components of that revised idea score, and you have sort of the human rubric here to enhance the amount of feedback. And the scope is internal medicine residents, hospital admission notes, and do AI-derived feedback on their clinical reasoning of their scope of their differential diagnosis. And again, you have the human gold standard here and how they explain their reasoning as well. And also read a lot of notes in this, and there's a big range, right? And so often the learners are just not getting enough feedback in this domain. And I think the other thing really important here is the importance of having a clear human rating gold standard in order to develop and base your AI tools on. So when you're kind of building these technologies for more kind of automated AI assessments, I think that's just something kind of just big picture to note here. I'm not going to do a drill down to, again, it was a complicated process. You have to reference the article here for those who wanted to read a little bit more about some of the nuances of the development. But for time, I'm not going to kind of go deep in the weeds on that. But just to kind of highlight, we actually did this before some of the explosion of the most recent large language models. And these are some of the technologies we use of, an earlier NLP model, SciSpacey, and then NYU Tron was developed at NYU specifically on EPIC data, is a predictive model, not a generative model. And similarly, actually, Gatortron, which is publicly available, which is what we ended up using at University of Cincinnati because NYU Tron wasn't transferable, also trained on EPIC notes. So again, sometimes some of these tools of what they're trained on are better for these use cases if you're using complex patient care data. And as we know, our language and notes is very specific and different probably with anything that's documents on public websites. This is the ultimate output, and I'm happy to answer the Q&A about the development. But so ultimately, this is a resident-facing dashboard. Our internal medicine residents are able to view their own data. Every admission note they write gets a D and an E score, and we have kind of what those human rubrics are. You actually can click in and see the full rubric when you're on the dashboard of their quality of their differential diagnosis and their quality of their explanation of reasoning. We weren't able to get the model to do the 3-point Likert scale because the explanation of reasoning is like a much more complex human task. So it's just a binary output for, as you'll see here, with the explanation of reasoning. And we did a lot of standard setting too. We reviewed a lot of data to create criterion standard. And you see, it's far from, we don't expect 100% of the time like this to be perfect. You see the targets here, right? You get post emissions for CAP. You don't expect a robust differential explanation for reasoning for that. And so kind of acceptability to the learner of this and, kind of is really important. And we have residents really involved in our development as well. What's helpful for you to see. And I think that's really important, that stakeholder buy-in of like, it's for them. It's formative. It's for their growth to supplement what the faculty are doing, for them to sit down with their faculty and use this as a tool. It's not to replace faculty. And again, they can see trends over time, targets, where they are, look at specific individual notes and kind of drill down as well. And from a program view, you can also then see an aggregate. And we've taken some of this data on aggregate, and we actually even used an earlier model we had developed for this retrospective study. But looking at, well, how might my clinical context shape clinical reasoning performance? And we're still talking about documentation now. I'm going to end with the accuracy piece of the work we're doing now. But just looking at these different factors, and obviously, these aren't happening in silo. It's happening in the busy workplace. Different patients, different contextual factors, what shift they're on, how many missions they're doing. And so we were able to, with the AI model, explore this that you just couldn't do with human rating because there's not enough time in the day, right? Like this was almost 40,000 admission notes. You can't rate all those notes with human rating, right? Like it's just not possible. And so we looked at a retrospective cohort over 5 academic years, so July through June, being the resident academic calendar year, almost 474 different residents, almost 400 admission notes. And looked, again, this is observational, so not necessarily causation, but we did a multivariable regression model to kind of control for covariates, and where we saw differences. So we saw differences by academic year. I think many may recall, 2020 in New York City, spring of 2020 was when COVID hit us really hard, and not surprisingly, so you see a dip here, and this is what would have happened to note quality if COVID hadn't come. And then you see continued improvement over time. And again, hypothesis generating, we implemented the 1.0 version of this dashboard here in 2020. So maybe it actually worked. That's great. And we also had, contextual changes, geographic wards, slight reduction in cap sizes, things like that. So again, just hypothesis generating, not necessarily saying for sure causation. And then other things we looked at of whether it was night or day shift. And the tail end is hard because, again, we just had to do a cutoff for attributions. That's why it gets a little mixed at the end. But when it's clearly distinct, whether it's a night or a day shift, there's a clear significant difference in just overall quality. Notes written at nighttime were significantly higher quality than during a day shift. And again, hypothesis generating. Residents are pulled in fewer directions overnight. They're focused on admitting. They're not doing discharges. They're only doing emergent consults. They're not doing like routine calls for studies and consults. And so maybe they're able to kind of focus further on their admissions. And again, this is just documentation and quality. Doesn't necessarily mean worse care per se. And again, I'll get to diagnostic accuracy in just a few slides. And then last thing here of, not surprisingly, the number of note and shift, the quality went down. Kind of surprising how quickly, by the time it was a third note in the shift, we already see kind of this big drop off in note quality. So again, just hypothesis generating and some of the kind of conclusions, kind of just went over just to summarize about those trends in academic year. We also look at patient characteristics, and patients that were older and had more comorbidities had higher quality notes, which makes sense. Might be sicker, might be more complicated. Often those lead to more robust documentation. And we saw certain diagnoses had higher quality notes. The residents just might be seeing these more often. Maybe they're, again, coming in with conditions that are more lend themselves to broader differentials. And then I talked a little bit about the shift. And so again, could inform systems changes, about what work's being done night versus day, or curricular changes of curriculum in the states where the disease states where they're not writing as high quality notes, and so again can potentially use from a program evaluation curriculum and systems changes perspective. And then just to wrap up, I'm going to talk about where we are now. And this is at using large language models to get a diagnostic accuracy and to get, and you'll see my work is focused at the trainee. Doesn't mean this is very relevant to any level of learner, including faculty. So all of this, it just happens to be, my work is focused within the trainees and residents. And you'll see the kind of the wonderful team here and some of the support for this work. And I will also just comment here as I'm showing kind of the team slide of, and I know probably everyone's coming from different backgrounds on the call here, of kind of doing this work. Like I consider myself a clinical reasoning education researcher. I don't consider myself an AI expert, right? I've learned enough about AI to be able to speak the language, the data scientists who know all the technical details, and to drive forward this work. And so I'll also comment on that for those that you want to do deeper work on this. I think there's a certain level that we need to know as clinicians and clinician educators. And like if you want to do then deeper like research and work on development, probably that needs to be a little further. But you don't necessarily need to be like all in the weeds of the technical. And so I just want to comment on the importance of sort of like the building teams around this. And this is just a big picture overview, and I'm just going to, and I might, for time, make sure we have time for Q&A, zip through some of this more quickly than others, but I'll zoom in a little bit on this, each of the slides, but just to give the landscape first. Ultimately, we were looking to use large language models to create essentially like identify cases in the electronic health record. And we started, again, we're doing this at one disease state at a time right now based on the models that are available. And so we started with venous thromboembolism. And ultimately developing prompts comparing to the resident, again, this is internal medicine residents on admission to the hospital, again, similarly to kind of the scope of the other work. Did they consider a VTE in their differential diagnosis? And was the case actually a VTE using the imaging reports, the narrative imaging reports as the gold standard? And then looking for any mismatch, reviewing these to see if it was truly a missed opportunity, and then creating some exclusion criteria based on those. And I'll talk about that in a little more detail in the subsequent slides. I will say we started also using ICD-10 codes, and it didn't get us anywhere. And so I think like as those doing research in this domain of this could be LLMs could be a really powerful tool, which historically ICD-10 codes have been used a lot in a lot of work like this. And they're like, again, those are, as you folks probably know, like they're used for a different intention and more for like a billing perspective. And so might not necessarily be like the primary thing that's going on with the patient. And those aren't always the same things. So just a little bit more about the prompt engineering for this. We use Llama was the on an internal run internally within our NYU system. So it's HIPAA compliant. It's kind of openly available Llama as long as you have the computing power to run it. And did a bunch of prompt engineering and iterations with human review to look at sort of the output, and ultimately was looking for just a yes/no output. Again, prompts for the admission notes to determine if a resident considered VT, and looking at imaging reports, and you see the relevant imaging reports that diagnose either PE or DVT listed there of whether it wasn't actually an acute VTE. And I'm going to show you the prompt. Obviously not going to read through all this. The admission note prompt was much more complicated than the imaging, so I'm just going to show as an example the admission note prompt. And this demonstrates the complexity of human language of all the different ways people talk about they're considering a VTE. And so you kind of sort of see a scope of this prompt of like, the key definitions, indicators of explicit considerations, things that don't reflect consideration. And then ultimately the final output from this is a yes/no. And we did certainly validation compared to human reviews and had quite high performance here. And you see again in a prospective unseen set from the prompt development set. And the only one I will highlight here that had lower performance, there's only like 3 true positives in this random sample of 100 was VQ scans. Ultimately, this is such a rare occurrence of like a patient only having VQ scan and not another type, PE study. We actually dropped that from implementation anyways, so a little less relevant. And again, this is all from a manuscript that currently is under review, so not yet published. And then this is just a little bit of overview then how we did some of the iterating on it and exclusion criteria, which I'll show in the next slide. And so we ran this on 2 years of data, over 20,000 admissions. Initially, we're using both ICD-10 coding and the LLM analysis of the imaging, of ICD-10 coding of the encounter entirety, and then LLM analysis of the imaging reports. There's ultimately 700 cases or 699 cases of VTE in this cohort. 137 were initially flagged as potential missed opportunities in diagnosis. And then I'll talk about our human review in a subsequent slide in just a second. But initially, a lot of these were not actually missed opportunities in diagnosis. And I'll go through some of those themes in a slide. And so we iterated on that with some exclusion criteria. to ultimately come up with sort of like the final kind of pipeline. And I'll add, I know the positive predictive value of 48% doesn't seem incredibly high. It is actually a lot higher than all the diagnostic error e-triggers out there in the literature. So it's a significant enhancement on what currently exists. And so this is just the human rating tool that we use. Again, as I mentioned before, it's really important to have a human gold standard when you're building these LLM or AI-based assessment tools of like, well, what are we looking for? And so this is based on work of Hardeep Singh of the Safer DX tool to do retrospective views of whether something was a diagnostic error. And it's not like a quantitative scoring system, but it kind of guides you through the chart to how to review a chart and come up in conclusion, was this a missed opportunity in diagnosis? Doesn't necessarily mean harm occurred with the patient, but should this diagnosis been made earlier or considered earlier? Two independent human reviewers, myself being one of them, reviewed these, and anything we were discordant on, we met and sort of adjudicated to what the final human consensus was. And so based on that, we added these exclusion criteria to again improve that performance. A lot of these were in-hospital complications, which wasn't the scope of what we're looking for here. Again, you could change the inclusion-exclusion criteria and only look for cases after 5 days to do some quality improvement about in-hospital complications of VTE. So that's something kind of note here. Again, ICD-10 codes did not yield much fruit, and we actually dropped that from implementation because it was causing more problems. And none of these cases were found by ICD-10 code alone. I'm not going to read through everything on this chart, but the one other thing I will highlight is the majority of the ones that we were left with after the exclusion criteria were implemented were this bucket of clinical change or lack of clinical improvement. And so these cases were like, oh, well, based on the data that was present on admission, there's no way they could have known this was coming. But these are also still potentially good cases. One of our guiding principles of like the inclusion criteria were, are these helpful cases to be flagged for review, right? It's about, where cases where you got things right and wrong in terms of, and I'll talk about, our implementation plans in just a second. And so if you kind of included these as like true positive, it actually is like the positive predictive value of this was in the high 70s. And so this is ultimately just kind of highlight of that, of like how many cases, 27 of them ultimately of the VTE cases being missed opportunity diagnosis. There's a whole range in the literature of what the national kind of rates are, and honestly, they all use different denominators, so it's kind of hard to fully compare, but some as high as 20%, some down at 1%. So this is obviously, there in the mix. And the other things we did is pinpointing missteps in the process, and this is the DEAR taxonomy by Gordy Shift. A lot of these we were found by hypothesis generation, but some other, and you see some case examples, misinterpretation of tests, of physical exam, or not gathering sufficient history. And I'm going to probably speed up a little bit just to make sure we have time for Q&A, just a few slides left. And then themes of how things were mitigated as well. And this is just thematic analysis, because this will also help inform intervention. So expert advice was a big bucket. So whether that be consults or supervising attending, because again, these are resident cases often done overnight. They don't get staffed by the attending till the next day. Worsening symptoms or lack of improvement, and that maybe prompted reevaluation or reassessment, and then a few cases in this other bucket. I'm not going to, for time, read these out, but again, so I'm just, these are just some vignettes to kind of give it a little bit more flavor, but I just want to go over quickly the planned implementation and leave time for questions. Oops, sorry, just like skipping around a bit. So as I already mentioned, again, about giving the feedback, it's about calibration. So we learn from where things went right, and we learn from things went wrong. And diagnostic performance feedback is about a well-aligned, calibrated physician. And so this is also work of Hardeep Singh and colleagues, the Calibrate DX tool. And we're building out our own survey, but kind of grounded in this. And these are just some snippets from the Calibrate DX tool. But again, we're going to be, and I'll show you on the next slide, a prototype of the dashboard, get residents their own data so they can reflect, choose cases where things went right, where they went wrong, how they might want to do things differently next time, reinforce what they did right and how they might continue to do that, and really help with that calibration. And so this is, again, this is just a prototype. We're still finalizing this. Again, our hope is to launch this over the summer of, again, all their VT diagnoses, if they have any missed opportunities for diagnosis, other contextual factors, what post-grad year they are, which team they're on, night or day shift, what number of note. So some of those factors I showed in that kind of prior data that might impact in context. And then there's balancing measures too. And this is going to look a little bit different, but they're ordering patterns over time, percent positivity rate. There isn't an absolute comparison of what's right. Again, it's about the calibration, the context, but for them to be able to reflect and review their own data and to kind of to help sort of calibrate them. And so ultimately, of course, we will measure impact, and our ultimate goal is improving their calibration and certainly accuracy over time. And the accuracy part is a little harder to get at because the n's so small, so certainly a lot of process measures to measure here, ordering behaviors, confidence and accuracy. And then really what improvement goals they're setting. So just to kind of wrap up, I know that was a little bit of a whirlwind. Diagnostic errors are still a thing, and again, this is the area we all need to do better, and that's despite lots of work on enhancements in clinical reasoning curriculum and assessments, and certainly system-based things. I know today's talk is education focused, but obviously, of course, that's not happening in a silo in the system. AI is a powerful tool that can assist in teaching and assessment of clinical reasoning. Whether we like it or not, our learners are going to be using this, so we need to teach them how to use it properly. As clinician educators, education leaders, education researchers, we need to be part of the teams and the voice at the table conducting the research on development, as we need to learn more about best practices of how to use these tools. This stuff is fun and cool, and it's going to allow us to innovate and do our job as educators. I already highlighted some folks along the way, but obviously it takes a village, and so just to kind of recognize those acknowledgments of the different individuals, funding sources that really support this work, and left some time for questions.
Excellent. Thank you, Dr. Shea. That was incredible. So much information about AI and clinical reasoning and what you're doing with your work. And we have quite a few questions, so I'll get right to them. A couple of questions about open resources. One of those is, are the manuscripts available for training? A lot of publications are behind paywalls. So people were asking about that and about the AI tool from NYU.
Yes. So the large language model paper, that's an open access paper. And I don't know if I certainly feel free to, I guess, email out follow up if the rest of people didn't catch the reference on the slides of. So that one definitely is an open access paper. Unfortunately, NYU-tron is not publicly available, and we tried to do contract execution when we were again partnering with University of Cincinnati, and so that's why we pivoted to using Gatortron, which is an open access. And again, the manuscript kind of goes through, I know I didn't get into the weeds of all the technical, but goes through all sort of like some of the technical development. So that was a big lesson learned. And one of our goals for that was generalizability and to use tools that could then be implemented at other sites was a big goal of that work. And then, yeah, in terms of model, again, for the most recent work, again, that manuscript's under review, so it's not accessible by anyone yet. Hopefully soon it will get published. But that's, we use Llama in that, which is an openly accessible instance of LLM. Again, you have to have like the right computing power to be able to kind of run it, I guess, internally within, HIPAA under your like own institution's firewall, which is only a caveat. So there are some LLM tools that can be run even if your institution doesn't have its own, because we also have a contract with OpenAI, an internal instance of GPT, but that's like, again, that's not anyone can kind of run that. Your institution has to have that contract, if you will.
Great, thank you. Okay, another question. Can generative AI shorten the time taken for human clinical reasoning? Would this mean that doctors can see more patients and make fewer mistakes?
Yes, I mean, I think that's like the double-edged sword of like, oh, this is going to make us more efficient. And then they're just going to increase our panel sizes or our cap sizes on awards. So, I think that is certainly, and as you could probably tell, I'm an optimist about all of this of like, hopefully this will bring us back, maybe not to have then too much more volume of patients so we can balance and spend more time on the things that I think many of us of why we became clinicians in the first place, of like the pure human aspects, and the, sitting at the bedside with our patients, again, the complex cases, like the higher order critical thinking. And so my hope is it gives us more space and time for that and doesn't just get replaced per se with more patients, but obviously from a system and a hospital administrator perspective, obviously that is something that might happen. And so I think, again, for us to advocate for the balance here for sure.
Absolutely. How effective is generative AI in incorporating cultural context in clinical reasoning?
Yeah, so I think that's and I mentioned one of the limitations is certainly is a limitation. That being said, is you with your prompt engineering, part of your iterative prompting to provide that context. So it definitely might not at first pass of like, this is the case, what we should do if you don't give it. But for an example, again, if your patient's a Jehovah's Witness and they don't want like, alternatives to blood transfusions, it's not going to come up with that on its own, like unless you give it that information. And so I think, again, it is with prompting, you can definitely kind of iterate to kind of provide like, this is the value system of my patient, what's important. Given this information, what do you suggest? Doesn't mean it's going to be 100% right. You got to critically appraise the kind of that output and then put it into context but it definitely can help open your eyes and think about different things that you might not have thought about before.
Yeah, absolutely. On the topic of a decision support tool, have you seen the students being more likely to lean on that AI decision versus using their own reasoning? And what approaches have you taken for the best student outcomes?
Yeah, and so I don't think I use these words yet, and we talk, there's like the big concepts about like de-skilling, or even worse, like never skilling. And so I think that is the balance absolutely we have to strike. And that's why, again, like the way we just introduce it into our curriculum of like, do your human reasoning first. Like, right, this is again to layer on, not replace. You can't critically appraise that output unless you've developed the skills yourself. Does that mean that they're going out and doing that? I can't promise you. But it's something that we really hit home in terms of how we introduce it. And again, why I spent the time up front about what we know about human reasoning, and we certainly do that as well, without getting too theoretical, getting, a little bit more practical for that setting versus, a talk like this, again, how you integrate this in your process and doesn't replace it. And really that using it as a diagnostic decision support tool, right? Not replacement.
Okay, just a couple more questions for
Yeah.
you. AI could be a great context or resource to reduce bias. Have there been any studies about that related to diagnosis? And this person's really asking about well-resourced and less resourced institutions. So for example, not considering a differential because they don't have adequate testing or treatment resources, or considering something they might not have considered just because they do have those resources.
Yeah. Yeah, no, I think, it's definitely a really important conversation right now, sort of access to these tools and like access in a HIPAA compliant way, right? Because I think there is certainly more kind of just global access of like some of the public tools, and there's free versions of GPT. Granted, they're older models versus like the paid subscription, of course. But you can't put patient specific information right in those in terms of your making decisions about clinical care. And so I definitely think it is the responsibility, and you being one of those institutions that are more resourced and to put out some of the work or share some of those resources, like the website that I showed you again, that's publicly available for the institutions that aren't able to develop these tools on their own, to ensure that there is equity around this. And it potentially could help too, again, in that diagnostic decision support lens, like you don't have that consultant for that thing directly available, could potentially be helpful in some additional kind of a diagnostic decision support, and you don't have the rheumatology consultant like readily available to you from a kind of, I guess, a resource perspective. Granted, of course, you still need to be able to critically appraise that output, right, in terms of coming to the final decision, but better than not having it at all, probably.
Yeah. Okay. Another question. And I think just because I've read some of your work, I think I know where you stand on this. But given that AI can generate accurate differential diagnoses, if it's given the necessary clinical data input, have you changed your focus on teaching clinical reasoning or the curriculum for students? And if so, how?
Yeah. Yeah, and the change is really bit like again I see the maybe this will be different even 2 weeks from now. Today, I don't know exactly 1, 2, 3 years. It's still human plus AI, and I think that and human plus AI hopefully is better than human alone, and that yes, the straightforward bread and butter stuff might become more automated and AI alone, but not these nuanced things. So all the more reason, like it's that much more important we teach, human reasoning, and how we integrate these tools to make, enhance our reasoning. But really about, again, how do you use this to improve and develop your skills? There are some things that are going to become automated, like summarizing data in your notes, like that's going to already, other institutions have this stuff implemented. But it's going to be that much more important to be, and certainly ambient AI, which I know I didn't really, talk about as much of this, of helping with documentation and automating that stuff. But again, that almost gives that much more importance to that final synthesis statement of like what's going on here, right? Like, and that actually becomes that much more important. Like, yes, we might not have to teach about how to write up the full, data and pulling things from the chart because AI will automate that for us, but actually puts that much more emphasis on that higher order reasoning is the thing that's left for us as humans that we need to do, and work with AI on, if you will.
Absolutely. So, for all of the healthcare educators who are here today, what do you want to leave them with as far as how should they continue to teach clinical reasoning?
Yeah. Yeah, I think again we can't ignore it either. So we still certainly need to teach, and I kind of went briefly over some of the human best practices and talk about problem representations and illness scripts and diagnostic schemas and diagnostic timeouts. And then how does AI help us develop those? And, I didn't much get into certainly, and talk just very briefly about some of the use cases. Again, the AI can be a virtual tutor where you could practice these skills and get feedback, because a lot of this is about, feedback and iterating on problem representations, which is certainly a lot what the NEGM Healer platform does as well. And so using this as a coach tool, and layering AI into both the diagnostic decision-making process, but very much so it's also just in terms of assessment and feedback and coaching, such a powerful tool.
Thank you. So we would love to chat more about with you. And for all of you who've joined us today, thank you so much. Thank you to Dr. Stepnowski for the demo of NEGM Healer. And thank you again to Dr. Shea for that presentation on AI and assessment. Thank you so much.